So thank you for that kind introduction. I'm going to be talking about the Western European perspective and focusing on the UK. So if we look at the number of people newly diagnosed with HIV in the UK from 1998 to 2018, the number has reduced. In 2004, we had around 8,000 people newly diagnosed, while in 2018, the numbers were down to just under 5,000, and the numbers in 2019 have fallen a little bit further again. Now, if we look at, on this next slide, the setting of where newly diagnosed adults are diagnosed, and what we see in the UK, most people are diagnosed in hospital settings, so either in sexual health clinics, the antenatal clinic, hospital wards, the A&E department, or outpatients, and small numbers diagnosed in primary care. If we, though, however, look at different patient populations, injecting drug users, only 42% of them are diagnosed in sexual health clinics, while if we look at gay men, 75% are diagnosed in sexual health services. And our sexual health services are very well set up to deal with immediate treatment if that's needed. But in many of the other settings, patients will have to be referred into sexual health or HIV clinics. And although most clinics will have rapid access, it may not always be on the same day. On our next slide, if we look at antiretroviral coverage in the UK, and again, this is data from 2009 to 2018, we've seen a great improvement in patients receiving treatment. In 2009, only 82% of patients were with an HIV diagnosis were on therapy, but by 2018, that had increased to 97%, well above the WHO-UNA target. When we look at the proportion of patients receiving antiretroviral therapy, again, you can see here that actually across all groups, so all genders, age groups, ethnicity, exposure group, and region, had antiretroviral treatment undetectability of over 90%. But the two groups that I want to focus on who underperformed were the young 15 to 24-year-old age group, which was only 95%, and injecting drug users, 96%. So perhaps highlighting individuals which may need greater support. So when we look at the proportion of new HIV diagnoses starting treatment within 3 months of exposure by group, this is data again from the UK from 2014 to 2018. In the top left, what you can see is the proportion starting treatment within 3 months with a CD4 count over 350, and seeing that a much higher proportion of Black African heterosexual women and gay and bisexual men started treatment rather than people who inject drugs and Black African heterosexual men. We see a very similar picture for those patients presenting late with a CD4 count less than 350, but certainly doing better than those presenting earlier. When we look at age at diagnosis, we see that it is the younger age group that underperforms when compared to their older patients. Having said that, when we look at the proportion of people with antiretroviral therapy with a viral load that's undetectable by age group in the UK, in 2018, we see across all age groups that patients are reaching or almost reaching the 90% target. But again, it is that younger age group that are underperforming compared to their older individuals. When we look at our key recommendations when to start antiretroviral therapy, all our guidelines really come up with the same advice, and that is that ART should be started as soon as possible after HIV diagnosis, and that includes immediately after diagnosis if the patient is ready to commit to treatment. But we must make sure that we have structural barriers that delay the receipt of ART can be removed to allow newly diagnosed patients to receive antiretroviral therapy at that first clinic visit, if appropriate. And ART needs to be started for most opportunistic infections within 2 weeks of diagnosis. I think there's a lot of debate about when to start antiretroviral therapy on the basis that what we want to make sure is that when the patient is ready to start, that there is the availability to do so, and that this should be can be either immediate or same-day antiretroviral therapy, starting on the day of diagnosis or at the first clinic visit when they need to be referred from the setting where HIV treatment is not available. I think that there is also the view that what may be equally or maybe more suitable for some patients is rapid ART, which is initiation of treatment within 7 days of diagnosis. So I think that when it comes to thinking about whether starting treatment immediately, delaying a short period of time, I think that one has to think about a number of different issues. Starting treatment immediately on the day of HIV diagnosis will mean that you're going to have to choose an antiretroviral therapy regimen when you have only limited information. You won't have an HIV viral load, you won't have the result of the resistance test, you won't have an HLA B5701, which excludes using abacavir as part of that regimen, and you don't either have a hepatitis B status. I think that that very much leads you to have to think about a treatment regimen which will have a high barrier to resistance. You won't have the results of the viral load, so I think one would have to be cautious in terms of thinking about using a 2-drug regimen. And in this setting, I would always want to start with a 3-drug regimen. You may not have other information in terms of a full list of the patient's other medication. You need to make sure that you have access to support from a pharmacy to make sure that drugs are available. There needs to be staffing in place to address not only the medical needs, but also the emotional support that patients may need, and practical support around whether patients have adequate housing and access to resources to pay for food, and also access to emotional support in terms of counselling or clinical psychology. I thought that a good way to think about how to manage new diagnosed patients and whether immediate starting of antiretroviral therapy was appropriate was to think about 3 cases that I've seen over the last month or two where we've had very different decisions about starting therapy. So I'm going to start with my first patient, who's a 32-year-old man who attended our local STI clinic for a routine STI screen, including an HIV test with his new partner. This was a new relationship. He was found to be HIV positive, and his partner was found to be HIV negative. He'd had an HIV test 6 months ago, and at that time he was HIV negative. And clearly his concern was that this is a recent HIV infection, and that he needs to start treatment sooner rather than later. I wanted to discuss treatment and wanted to discuss whether it was possible to start on treatment today. He also had quite clear views about what treatment he would want to start. He said that he wanted to think about starting on a 2-drug regimen, because he'd read that this there was now good information to say that this was possible to reduce potential long-term toxicities. The discussion that I had with him was that I thought that it was important that, as we didn't have a baseline viral load, and that I might think that he might well have a very high viral load, that he would be much better to start on a 3-drug regimen. I also discussed that I thought that it would be important for him to start on one of the second-generation integrase inhibitors because of the ability, because of it getting the viral load down quickly, but also having a high barrier to resistance. And this patient, at the end of the consultation, was keen to start treatment and started on a 3-drug INSTI regimen. We've seen back in the clinic months later, and I'm pleased to report his viral load was undetectable. The second patient that was a challenge was a 29-year-old patient who was sent to my HIV clinic from our antenatal clinic. She was a late booker. She was found to be 27 weeks pregnant, and as part of her antenatal screen had undergone an HIV test. She never had an HIV test previously and was clearly absolutely devastated by the result and the implications that that might have for her pregnancy. She did have quite significant medical problems from the point of view of her pregnancy. She was hypertensive, she had some mild ankle edema, and the concern of the obstetrician was that she may go into early labor and concerns about getting her viral load down as fast as possible. She did have a past history of depression and anxiety, and the concerns was that she was a single mother, but did say she had close family support. I think she was rather overwhelmed by all the information she had to take in that day, and said that she would be willing to take treatment, but she needed to go away and just think about things. In fact, she came back the next day, having discussed this with her mother and also a couple of friends, and was very keen to get on and start treatment. So an example of on the day wasn't the best option for her, but having thought things through, came back immediately to start on treatment. And the third patient I wanted to discuss was a 42-year-old patient, single man, works in a very high-pressure job as a lawyer. He presented with shingles. His GP had seen him, started him on some valacyclovir, but had quite rightly identified that he needed to have an HIV test as a possible cause for his shingles. Shingles was very painful. He was on a lot of analgesia. He was also having difficulty sleeping at night. He was taking some sleeping tablets. When the HIV diagnosis came back, he was referred into the clinic. And on that day, we started to talk about treatment. He very clearly took a view that he had a lot on his plate at the moment. He didn't like taking multiple drugs. He was concerned about multiple drug interactions. He also wanted to think about his options. He wanted to have more information as to whether he had any baseline antiretroviral resistance, and really wanted to look at all his options and didn't feel today was the right time to start. and indeed went away. And a couple of weeks later, when his pain was much better controlled, he was keen then to start treatment, which I think was the time that was correct for him. So I think in summary, every patient has different needs, and I think it's very important to be able to give patients options and to be clear that one size doesn't fit all. I think in the UK at the moment, we have that flexibility, and I think that we, clearly, from the results of our patients on antiretroviral therapy and the percentage of our patients who are undetectable, I think that this flexible approach works well for us. So thank you.